He starts with a case of a person who's on way too much prednisone, who has bad RA, uncontrolled disease, and is previously heavily treated with biologics and non-biologics. You're trying to make a decision about to escalate therapy in a patient like this, and she wants to know, and you want to know, what is the safe choices here. So we have this big palette of drugs, and all of them carry pretty heavy-duty warnings here. And is there a way to sort out relative risk moving forward? And we'll make a few editorial comments about this. At 30,000 feet, you can see that the risks of serious infections, non-serious infections, bacterial infections, some package insert related admonitions about hepatitis and zoster are widely distributed. Some rarer diseases such as progressive multifocal leukoencephalopathy is much more heavily restricted. So we have some tools to work with. We can assess risk. We have some risk mitigation, but there's a lot of worry involved in terms of both patient and doctor. So the best practice is to assess the severity and the activity of the disease, because this has been shown to be risk factors for this. We can't emphasize enough, and Kevin alluded to this already several times. We're so focused on the biologics, where study after study after study shows it's glucocorticoids that are the greatest risk factor for virtually all of these things, except for perhaps some of the opportunistic infections. Comorbidities are important, local regional factors, and maybe we'll say things about surgeries. I won't belabor the fact that there's a dose-dependent increased risk of infection with glucocorticoids, and certainly when you see a patient like this on 17.5, they're in big trouble. They're almost in the territory where you start thinking of pneumocystis prophylaxis. We gave a quiz question about this the other day. But if you look at serious infection rates, those are the kind that put you in the hospital, give you parenteral antibiotics. Virtually all the studies coming out of randomized controlled trials are somewhere between about 3 and 9. But that's in clinical trials, and most of them are far less than that, as you can see over here for biologics. Those are not real-world data. These are clinical trial people that have a lot of comorbidities are censored. They don't get into this. And when you start looking at serious infections getting out into the community and registries, it becomes far higher. This is what you start seeing in registries, getting up to this 5 or 6 per 100 patient years. And if you start substratifying for age and prednisone, it gets even higher. Here's what we see with comorbidities: elderly, immunocompromised, chronic lung disease, and long-term steroids. These are crazy, numbers in terms of cases per 100,000 patient years. So, skip this. Everybody knows that with rituximab, immunoglobulins is a biomarker for infection, and it's IgG, not IgM. IgM will decrease in over a quarter of patients, but after moving on to this, I check immunoglobulins baseline in all patients I give rituximab to. Why? Because it's the only time that you will have a immunologically naive population to assess this. I never check them again serially. I wait till the unfortunate event, if there's an infection, then I check them and modify accordingly. This is a slide that tells us that not only are the drugs important, so ranging from conventional synthetic DMARDs to DMARDs plus glucocorticoids, but comorbidities. You add DMARDs and glucocorticoids in high dose, and 1, 2, or 3 comorbidities, and the risk of infection goes through the roof. So you need a prevention plan. We've talked a lot about vaccination. We need to identify who's at risk. We need to identify specific surgeries, and we need to think about certain infections. Who has used the rabbit risk calculator in here? Okay, we have a few people. I like this, and I put this in my notes for patients, particularly referred for these questions. So there's a calculator. If you just go to rabbit risk calculator, it comes right up. This was developed in the rabbit registry in Germany, and it puts in age, prednisone dose, prior DMARDs, prior history of serious infection. It gives you some time parameters and current biologics. So here's a 47-year-old, no comorbidities, 2 prior DMARD failures, tender swollen joints, 3 hack, methotrexate and prednisone, and you're going to put this patient on what is the patient's risk moving forward of a serious infection. It's 1.4 at baseline. Adding a TNF makes it 2.6. This patient is 62-year-old and has COPD. His failed many prior DMARDs, has more active disease, more disability, is on high-dose prednisone. Doing the rabbit risk calculator on this patient tells you something like this. A high baseline risk and a remarkable elevated risk. This is largely being driven by prednisone. But I like to do this, and I think it's helpful to see this both as a physician and from the patient. Surgery recommendations have been mentioned previously, and ACR publications and these consensus documents still are have some controversy in them, but for the most part, the data drives suggest that you really don't need to do very much, though few of us, in terms of our practice, would want to subject a patient to a major non-sterile surgery, not something like cataracts, but abdominal surgery, should it be elective, in the peak of a TNF inhibitor. Tuberculosis risk driven by countries. Here's the map again, Bruce. So it's like looks like hepatitis B. We divide the world into high risk and low risk. Low risk is less than 100 cases per 1,000 patient years. In the United States, we're down to just a couple cases per 1,000 patient years, and there are parts of the world that are far, far above 100. And like hepatitis B, where the leading risk of hepatitis B in the world is immigration from an area of high prevalence, similarly for TB. You all know the data on risks for TB. This are looking at all the TNF inhibitors. The only reproducible findings, and we think that the certolizumab is probably some channeling bias from a particularly high-risk background areas of study, that etanercept has shown to be far lower, and the only biologic that doesn't carry this, at least in this group, is the IL-1 inhibitor. Prednisone and TB, bad news. Odds ratios are dramatically high, and this is the one thing that we really need to work on. So how do we screen for these people? This is a study that was actually done by Jack Cush, looking at a large population of patients in the golimumab trial using both TST and IGRAs. In this audience, who screens with skin test TST? And who screens with IGRA? Wow, look at that, that's crazy. And we do too. So the good part about IGRA is that it's, it's reproducible, it goes right in the electronic record, it's trackable. The bad things about IGRA are two things. One, indeterminate tests, which we've looked into in the past, can't get around this, particularly related to what? Glucocorticoids. And the second thing is that should you be engaged in serially testing your patients, you're going to be in trouble in interpreting this, because what has been seen with all populations, particularly in healthcare workers, that there is a more than expected fluctuation of negative to positive, positive to negative, right around the cutoff value. And thus, the recommendations of the CDC are what we adhere to. We don't repeat the PPD unless there's been a major change in risk, or PPD or IGRA, unless there's been a major change in risk. There are areas, and I know Jack Cush lives in this, Texas, people coming back over the border, where he repeats these tests, but that's driven by risk, not by anything else. Hepatitis B. I'd like to make a couple comments on that because we don't do extraordinarily well for screening hepatitis B, and it's important. We describe this infection as deadly but preventable, and it is so preventable. And we were talking about these, Kevin and I were talking about at dinner last night, the guidelines. The reason that we do so poorly in monitoring hepatitis B serologies is that we have such abysmally poor guidelines to give us a best practice. I suspect that in the next iteration of ACR guidelines, hopefully this will be changed. But recently the AASLD has worked collaboratively with numerous societies to come up with a screening guideline that makes a lot of sense. You know that the people at greatest risk are those that are surface antigen positive. The people at the least risk are those that are anti-core and anti-surface positive. Obviously, if you're seronegative, you have no risk. So we try to address these people. The take-home message of this slide, which we've written about a lot, is that you don't have to ask about risk. You don't have to ask about where people are coming from. You don't have to do anything. You ask a single question. Do you plan to give this patient immunosuppressive therapy? If the answer is yes, then you screen them. And the screening is surface antigen and anti-core total. If you want to check anti-surface, that's for preparing people to identify vaccine candidates. The second thing that they did was that they triaged drugs into three buckets. Those that are the highest risk for reactivation, which are basically rituximab, the only drug that we have that carry a black box warning, TNF inhibitors and other biologics, and then synthetic DMARDs in the lowest risk category. And you combine these to create a way moving forward. All surface antigen patients who are immunosuppressed need to be on antiviral prophylaxis, all of them, regardless of their HBV DNA status. I'd be happy to answer questions about core. Most of them require just careful observation, baseline HBV DNA moving forward. Kevin's talked about zoster, talked about stroke. Who shouldn't receive TNF inhibitors? Active hepatitis, patients with advanced parenchymal disease of the liver, very difficult. Patients who have been treated but have resistant non-tuberculous mycobacterial infections, we're going to broach some of these in our cases moving forward, and probably broach the issue of HCV. Inappropriate practices, I told you, IGRA on a regular basis is really not indicated. If a patient is known to be positive for TB, and I'm going to come to you with a case for this, we don't need to test them again. There's risk mitigation using JC serologies for drugs like natalizumab, but there are no recommendations whatsoever to do baseline JCV screening for patients receiving any drug for a rheumatic disease. And that's an important thing. Best way to avoid serious infections, control the disease. Disease activity is a huge comorbidity in risk. Screening measures, talking about assessing comorbidities, calculating risk scores, vaccines, and what Kevin didn't really have a chance to talk about is that the best way to increase our use of vaccines is to change the system, not to just kind of think about this. So to have something in place in your office, we asked put vaccines up on our TV monitors in our exam rooms so they can bring this up if we're not bringing it up. And certainly having it through your EMR or advanced practitioners do a far better job at doing this than we do. Avoiding excessive glucocorticoids, controlling comorbidities, and talk to people about infection rules. That's really important. I know that this is a best practice. I mean, we don't want to have people on 12.5 of prednisone, a TNF inhibitor, to be calling their primary care physician for their third Z-Pack because they're not getting better over the past 3 weeks and with fever and night sweats and cough. So they need rules when to engage us. More on this. I'm actually going to stop to get us back on time here because Jack has about 66 more slides left in this deck. He would have been done by now if he was giving this talk. So I will wrap up with the following comments of shared and informed decision-making with patients about the risks of infections and the drugs that you select. Rheumatologists select drugs primarily on the basis of safety more than efficacy, and I think that this is good. Prevention, vaccine strategies, infection rules, and make sure you have a good infectious disease practitioner or group to collaborate with.